Some patients can develop sacroiliac joint dysfunction, which is the joint between the tailbone and the hip bone. And that joint, once it gets inflamed, it can cause pain to radiate into the buttocks and into the back of the thigh. For those conditions, once accurate diagnosis has been made, it's fairly simple to treat it. So again, if we are on the ball, understanding the diagnosis and treating it, that prevents these conditions from becoming chronic in nature.
Welcome back to the Kentucky Pain Reversal Show. In episode 1, Dr. Nair explained how many Kentuckians get pulled into the pain spiral. And then in episode 2, we talked about why pain medications often lose their effectiveness over time, not because of weakness, but because of biology. But today, we're going even earlier in the pain journey. Most people believe that once you get imaging, start physical therapy, and do all the right things, pain should improve. But for many Kentuckians, that's not what happens. Instead, weeks turn into months, pain lingers, and frustration builds. In this episode, Dr. Nair helps explain why early pain care can sometimes miss the mark, even when everyone involved has good intentions, and how timing, biology, and the nervous system all play a role. So let's continue the conversation. Dr. Nair, after talking about pills in episode 2, I want to take a step back and go a little earlier in the pain journey. So when someone first gets injured, what usually happens next in our standard healthcare system, and why does it often feel so confusing for patients?
Well, for many patients, it depends on the type of injury. Since we're talking about injuries, the most common injury would be a disc herniation, when a patient suddenly feels a pop after lifting a heavy or moderately heavy object, and then they develop this stinging, painful sensation that radiates down their leg. That's the most common presentation. You could have similar signs and symptoms in the neck, or you may have a constellation of symptoms, let's say after having a car accident. So it all depends on what the cause of the injury is and where the pain generators are located. You also can get pain, let's say somebody who was newly diagnosed with cancer, and let's say the cancer spreads to the bone. You can also have back pain, which could mimic a disc herniation or whiplash injury. So it is very important to understand the mechanism of injury, take a thorough history and physical, and then narrow down the pain generators. And at that point, you can know what are the protocols to follow to treat it. So let's say you've got a young 25-year-old who just went to the gym, came back, and has got this really sore sensation in their muscles in the back. And they think, okay, well, I think I must have pulled a muscle after going to the gym. And they probably will tend not to do anything for it. They might take some muscle relaxants. They may take some anti-inflammatories. They may go to their doctor, who may suggest the same things. So they may sit on it for some time, and it may be a simple case of muscle spasm, a little bit of rest, taking some vitamins, some magnesium, putting their feet in some Epsom salt. That might solve the problem. However, if the problem doesn't go away and now the symptoms increase, including having tingling and numbness and weakness go down the leg, then that is a good indication that there may have been a herniated disc or a bulging disc that is causing irritation to the nerve roots at that particular level of the spine. What would be the best thing is seeing their primary doctor or a specialist and getting diagnostic tests done, such as an MRI. Now, here, we're assuming that the patient has already done more conservative treatment, like, let's say, physical therapy, muscle relaxants, anti-inflammatories. If those things haven't helped, then I think getting radiological studies to understand the problem further. Now, let's say this particular patient developed a herniated disc. I think it would be advisable to continue physical therapy for maybe another 1 or 2 weeks to see if things improve. Maybe even take a oral steroid dose pack, even though I'm not a very big fan of that, but that still may reduce the inflammation caused by the disc herniation. So it's well worth trying it out. Now, if the pain still doesn't get any better, and if the MRI does correctly show that there's a herniated disc, then the patient should see a pain specialist to get an epidural injection. Now, there are specific epidural injections that will target the uh, the sciatica portion of the pain. So, going to a qualified pain specialist would be the next step. Now, I think that it's worthwhile to have 1 to 2 of these injections, provided the first one shows some improvement. Very often after epidural injections, nearly 60 to 80% of the radicular or sciatica pain can go away. Now, if it doesn't and still persists, then at that point it is worth, you know, getting a referral to a surgeon, an orthopedic surgeon, to get their opinion, not necessarily to get surgery, but to just get an opinion to know if there are any other more conservative ways to treat the problem. So here we're only talking about a herniated disc. There's another constellation of symptoms that can cause low back pain, such as degenerative disc disease. That can cause the small joints in your back to get arthritic and cause back pain. Some patients can develop something called sacroiliac joint dysfunction, which is the joint between the tailbone and the hip bone. And that joint, once it gets inflamed, it can cause pain to radiate into the buttocks and into the back of the thigh. For those conditions, once accurate diagnosis has been made, it's fairly simple to treat it. So again, if we are on the ball, understanding the diagnosis and treating it, that prevents these conditions from becoming chronic in nature. Now, of course, if it does become chronic in nature, then we've touched upon other ways to treat chronic pain in our previous episodes.
Yes. You mentioned that one of the first kind of tools that we reach for is going to a doctor to get an MRI done, and imaging. That's often seen as the answer, or the kind of first line of kind of identification into what's going on. Why do MRIs sometimes create perhaps more fear or misdirection than clarity when it comes to pain?
Well, that's an excellent question, because I have had many patients who have come to me and they have said, you know, after getting an MRI, it says that I have a bulging disc, but this pain that's going down my leg is unbearable. So very often when radiologists or surgeons, when they look at an MRI and they see a bulging disc, they'll say, oh, you know what, that wouldn't be causing you to have such severe symptoms. And sometimes the patients can get brushed off or second guessed. Now, the truth of the matter is, even with a bulging disc, what happens at the disc level is that some of the disc fibers may be disrupted, and the chemicals inside the disc can sensitize the nerves. And that's the reason why you develop this sciatica type pain, which, by the way, the MRI is not showing it, because the MRI is not showing that the disc is irritating the nerve. It's more of a clinical diagnosis and examination findings being correlated. So that's where I sometimes feel that there's a kind of mismatch between what is seen on an MRI and what the patient's symptoms are. In fact, I've had many situations where a patient will come with right leg pain, but the MRI is showing that there is left-sided symptoms. So again, a disconnect, but I always give my patients the benefit of the doubt, and I try to narrow down the pain generators. Sometimes an EMG or a nerve conduction study may also accurately point to which side the pain is actually perceived by the patient.
That is so interesting. It really is one of those things where you're reading between the lines or reading in between the images there, and what you see at first blush in the image might not actually be telling the full story. So that's so interesting that we could think it's one thing, but there could be another layer under there that you're able to identify. That, like you said, there's a kind of miscommunication or mismatch in identifying exactly what's happening. Many patients too are sent to then physical therapy, right, very early on in the process. And a lot of the times, physical therapy can be helpful, right? But in some situations, it can actually make that acute pain worse. Which, in which cases would it be helpful? And then in which cases can it actually irritate things or make them worse?
Now, by and large, I think physical therapy performed appropriately can give patients relief, whether it is for back spasm or sciatica. Very often, the physical therapist will have certain techniques known as heat ultrasound, where they can apply that to the back muscles, giving a fair amount of relief. Or sometimes they can offer traction, which takes a little bit of pressure away from the nerve roots. So that's good.
I've done both of those. They're lovely. I gotta say.
Right. So I mean, I definitely would advocate for physical therapy and physical therapists. Sometimes the pain does come back after a day or two, and hence I think it's important to consider other treatment options. Now, if I have a patient who's got severe pain going down the leg, then I would suggest to the physical therapist, hold off on traction. Let's get an epidural performed, reduce the inflammation around the nerve root, and allowing the back muscles to relax, and then perform physical therapy, which will be twice as beneficial at that point.
That makes a lot of sense. So you just mentioned that some of these acute injuries need rest and calming, not activation right away. Can you dive a little deeper and explain more about the difference between an injury that needs movement and one that needs some time and intervention and a little bit more gentle approach right off the bat?
Well, again, as I was mentioning earlier on, if the patient has conditions that are similar to sciatica, one should be cautious with physical therapy. But if the pain is mainly in the low back, then I do believe that traction and heat ultrasound would work better. And if the patient's symptom changes, then I usually tell my physical therapist, just pick up the phone, call me, and I'll try and get the patient in, get an epidural done, get those nerves to calm down, and they can continue their therapy.
Mm. At what point does kind of like a watchful waiting, hoping that things change, or repeating the same steps become harmful, turning, like an acute problem into chronic pain?
Well, I think in any chronic pain situation, or for that matter, pain that could potentially go from acute to chronic, I don't think a tincture of time is going to help that situation. I think it is important to get the appropriate referrals. And I know in this day and age, it is difficult to get referrals. Very often, to get into a specialist office may take months. But I think that there are enough specialists around there that the primary doctors can refer to somebody who will be able to get this patient in for quicker treatment. So I think time is of essence. I don't think that any patient should be harboring a condition for more than 2 or 3 weeks. They should be getting attention for it.
Mm. Okay, 2 to 3 weeks. That's a good metric to watch out for so that you don't extend past that. That's great.
Right.
Many patients here, we talked about kind of the almost like the misgendering of what's happening in an MRI. Many patients are hearing like, oh, it doesn't look that bad. The imaging, it could be worse, but their pain is really severe. How does that disconnect that we referenced earlier affect patients psychologically and physically?
Well, the first thing is we have to understand that when a radiologist looks at an MRI, they are looking at a static picture. They don't have the advantage that I have of being able to examine the patient and correlate history, examination findings, and the radiological findings. So I feel that sometimes a radiologist is making a diagnosis with one hand tied behind their back. And so we kind of should cut them some slack as far as that's concerned. But nevertheless, once the MRI do show symptoms and it's correlated with the physical examination, then treatment has to be instituted. The sooner, the better.
All right, good to know. Next question. When patients are told that their imaging is normal, but their pain still persists, how does that push them maybe back towards pills or unnecessary procedures? Does that almost facilitate the kind of addiction journey that we talked about last time?
Well, in some cases it can, but I feel that if a patient, after having an MRI, the MRI shows that there's no reason for you to have this pain, there can be many painful conditions that cannot be seen with an MRI. So, for instance, if a patient has been in a car accident, the small joints in the back get affected. But changes in those joints will take a few months to a few years to be able to be seen on an MRI. So that's going to be a clinical diagnosis. So I think that, to answer your question, if the MRI doesn't show any accurate clues as to what the problem is, I do believe that the treating physician should look at other tests, such as you can place numbing medicine into the facet joint or into the epidural to test and see if the disc or the facet is the cause of the pain.
Mm.
And when you use numbing medicine, you can now use that as a diagnostic test, which allows you to then prepare for treatment of that condition.
Yes, that's great. It's almost like a process of elimination through diagnostics, almost.
Right.
Um,
Sometimes I feel like I'm Sherlock Holmes.
I love that. You definitely are. Dr. Nair, in your experience, what would an ideal early pain pathway look like? One that actually reduces the risk of chronic pain and keeps you in that window of where we can manage it within that month.
Well, I would say this, you know, for the patients listening out there, even if they feel that they suffered a trivial injury, that it might be possible that it's not a trivial injury. Even a disc herniation or a bulging disc, it can develop into a more involved problem down the line. So the sooner you get to see a healthcare specialist, get to an examination and diagnosis, the sooner you can know what the problem is and what the treatment options are. You don't necessarily have to go through the algorithm of the treatment, but once you know what condition you have and what the treatment options are, then the patient can make a very informed decision as to what do they think they need to do next in order to get their pain under control. So it gives the patient lots more autonomy and knowledge about their medical condition.
And that's fantastic. That's where we want to live as patients, right? I think the way that doctors establish the most trust is when you're on the same page and you're speaking the same language, and they understand not the same level, but just as much, right? You guys are able to kind of trade on that information. For someone who's listening right now who feels like they've been stuck, repeating physical therapy, imaging, scans, maybe appointments with no progress or no clarity, like you just mentioned, what do you want them to understand or take away before we talk about surgery in our next episode?
Well, I think it's important to communicate with their primary care doctors, explain to them what's going on, how they're feeling, because very often the onset of pain can not only cause physical limitations, but it can really do a number on you psychologically. Because the inability to do their day-to-day activities can really put a damper on how you feel and how you look at various things in your life. So it's so important to bring it to your healthcare provider's attention so that the appropriate referrals and the appropriate diagnosis can be given to it and institute treatment. So I think like they were saying in New York, if you see something, say something. The same principle applies here. If you have certain symptoms that are outside of the ordinary, bring it to your primary care doctor's attention, and the doctor will do the appropriate referrals or at least counsel the patient appropriately.
All right. If you see something, say something. That's good. That's easy to remember. Awesome.
Let me quickly tell you about this lady that I was just seeing just before I walked in.
Okay. Yeah.
So it's interesting because we're in Louisville, Kentucky, and this lady comes from close to Cincinnati. Her healthcare providers are in Cincinnati. She has been having sciatica, degenerative disc disease, sacroiliac joint dysfunction, and she's being prescribed Percocet. And this has been a chronic situation. Now, she happened to see her endocrinologist, and the endocrinologist said, "Hey, you know what? We did some blood tests, and your blood cortisol level is pretty low." And the endocrinologist was very perplexed as to what could be causing this low cortisol level. So she questioned the patient. Have you been getting any medications, any steroids, any drugs from your cardiologist or your other doctors? She said, no, I see my pain specialist and I get my medications and I get my injections. So no. Then she paused for a second and she said, yeah, I get these injections a few times a month. And that's when the endocrinologist kind of, you know, uh, link the dots, so to speak, by understanding that these injections contained cortisol. And when you get cortisol from the outside, it can cause your body to reduce the production of its own cortisol level. Now, interesting enough, when the endocrinologist tried to reach out to the pain doctor refused to take the call and told the patient that if you don't do more injections, we are going to drop you as a patient. Now, this story tells you the true impact of the opioid crisis, because on one hand, the opioid crisis is because people are consuming a lot of opioids. But on the other hand, as I was telling you earlier on, doctors are equally responsible for this crisis because they profit from it. I cannot think of any other reason why this doctor in Cincinnati would say, if you don't do injections, I'm not going to write you pills. Because the pills are what they hold over their head to do the injections, which make them the money.
Oh my gosh.
Now, so I explained to the patient. Now, of course, there's another issue with having low cortisol because that can cause another very serious condition called Addison's disease, where your body is going to go into a shutdown mode because we depend on cortisol for our day-to-day activities, naturally produce cortisol.
Right.
And if that's not produced, the body can totally shut down. So I explained to her, you're lucky you dodged that bullet, but you still have the issue of chronic pain and you've been on Percocets for many years. So that's when I started the conversation about a pain pump. And I said, it's very possible that the pain pump may be able to take care of your low back pain, prevent you from being on injectable steroids, and give you better quality of life. And if in the event after a pump is put in and you have an acute flare up in a joint pain or low back pain, you can then get an epidural, which would have been far, a long time after your last steroid injection. So overall, making it a safer condition for the patient. So she was, since this was our new patient visit, she was very appreciative of the time and the information given to her. And she said she's going to think it over and discuss it with her family and maybe come back in a couple of days to talk about it further.
Well, thank you so much, Dr. Nair. And thank you for joining us for episode 3 of the Kentucky Pain Reversal Show. Today's conversation highlights an important truth that persistent pain doesn't always mean something is being done wrong. It often means that the right tools weren't used at the right time. So if you've been stuck cycling through scans, therapy sessions, and appointments without any real progress, know that you're not alone, and it doesn't mean that your pain is not real. So we want to lower the pills, lower the surgeries, and stop the pain. We will talk more about surgeries in episode 4.